running short of time, so may I request Dr. Sangeet, please, to talk about pseudophakic retinal detachments, please. We'll have some questions at the end of the talks.
So good morning, everyone. My talk for today will be on pseudophakic retinal detachment. And before I start, I'll just make a disclaimer that all the characters in the presentation are imaginary and fictional, and resemblance to any person living or dead is totally unintentional and deeply regretted. The views expressed are personal and not meant to hurt anybody. The aim is to provide guidelines as to perform cataract surgery, keeping in mind the vitreoretinal status of the patient, and goal is to have a happy and a satisfied patient. So friends, the slides are not moving. Yeah. So we all know that there is a risk of retinal detachment which increases after cataract surgery, and it is more in intracapsular procedure, and it is extremely high if vitreous loss occurs. And it is more, again, in patients who have myopia or symptomatic patients, and more after YAG capsulotomy for PCO. So friends, there are three types of cataract surgeons that I believe. The first category is the cataract surgeons with good VR knowledge. They will examine the patients pre-operatively, and they will do a proper fundus examination. The second category is cataract surgeons who know that there is something called retina and posterior segment, and they will have some colleague who will examine the patient pre-operatively, make a good assessment, and I believe that 99% of the cataract surgeons fall in this category. But there's a very little segment of cataract surgeons whom I call phacologists, who just have one thing in mind, that is to do a phaco and put some kind of lens inside the eye. And for example, I am showing this particular case. This was a case of pseudophakic retinal detachment. I thought I'll just reposition the lens and proceed with the cataract surgery. But when I saw the patient, the whole 1/4 of the lens was missing inside the eye. I have to change my approach. I have to remove this lens. The interior capsule was intact, so I did an interior vitrectomy from the cutter here, and then I proceeded with the intraocular lens implant. And then I did a vitreous surgery. So please avoid these kind of mistakes during the primary cataract surgery, because ultimately they will lead on to problems only. So management of retinal detachment in pseudophakic eyes, the first thing is to optimize the cataract surgery. So this is another video. You see here, there's a anterior chamber lens, the iris claw lens, and as soon as we start to do a fluid gear exchange, the lens tilts, and it's now standing perfectly in the anterior chamber. So to take care of this, just inject some viscoelastic into the anterior chamber, just to reposition the lens. Need not explant this lens. And once you have done so, you can proceed and complete your vitrectomy. And you see the IOL is stable even during the fluid air exchange. This is another problem which happens, the putative lens, which is now, you see, this is floating inside the eye while doing vitrectomy. So here, now again, you don't need to explant it, just do an optical capture behind the posterior capsule or the anterior capsule, whichever is there. And then you proceed on with your surgery. You can do a proper vitrectomy. And you see again, with the fluid air exchange, during fluid air exchange, the lens remains quite stable. So next thing is you improve the visualizations, because many of these lenses will develop membranes around them, and there will be a lot of problem while we are doing the surgery. And you see in this is a very old video, and there were a lot of membranes. Even the retina you were not able to visualize the retina while doing the surgery, so I have to spend a lot of time to cut all these membranes and to reposition this lens before proceeding ahead with the vitreous surgery. So always use these thin aptic IOLs, and always try to make a good capsular access, so proper visualization. Next thing is managing the retinal lens matter, which may be present in these type of PCO cases, which lead ultimately to retinal detachment. Another case, you see an iris claw lens there, and there was nucleus behind, and there was a total retinal detachment. So in this case, you have to remove whole of the vitreous before you attempt to remove the nucleus, because the increased suction while removing the nucleus may lead to your retina being caught inside the cutter and leading to the increase in the size of the breaks and the increase in the retinal detachment. So once you have removed the vitreous, you can use your cutter or your phacophragmatome to remove this lens matters and proceed ahead with the vitrectomy, with the settling the retina and doing a fluid air exchange or silicone oil exchange and silicone oil injection, whatever you feel like, depending upon the case. So in this case, now we are doing a fluid air exchange, and we put in oil in this case. So managing dislocated IOLs with retinal detachment, again, there will be a problem. Sometimes these lenses, because again, there is a PCO, most of these cases, this lens will dislocate. And this was a lens, a 3-piece lens, we could refixate it. The same lens, we can do a scleral fixation of the same lens. I generally do it make the pockets and put in the haptics in there. These, in cases where you have to do a tamponade, you need a good stability of the lens post-operatively, otherwise the lens will dislocate again. So here I am refixing this lens and proceeding on with the RD surgery. You can complete your vitrectomy and you see the lens is again very stable, even during the fluid air exchange. Sorry. So this was another case. In this again, there was a lens in which haptic was broken, and I had to remove this IOL first. And in these cases where detachment is there, I always prefer to put in a PFCL to stabilize the retina before I open the anterior chamber and remove the IOL. So next, once I removed the IOL was broken, so I had to remove it and putting the PMMA lens in here. Then proceeding further with the completion of vitrectomy, and you see again, the lens remains stable in this eye during whole of the surgery. So before some preventive methods, this pre-operative, again I would like to emphasize, is a meticulous fundus examination, especially in high-risk cases, and to treat all pre-existing breaks or lattices with laser or cryo are important. And during surgery, maintain the visualization. You clear the capsular bags and minimize the PCO. Choose compatible IOLs, and proper management of PCR is important during surgery. Thank you.
Thank you, Dr. Sangeet. I think you have another course to attend, so we will excuse you on